Good day everyone. I'm Ivan, the moderator for this webinar. I welcome everyone to today's webinar, which is CMS Hospital Restraint and Seclusion, Navigating the Most Problematic CMS Standards. I want to introduce our presenter for today, Laura A. Dixon. Laura A. Dixon, BS, JD, RN, CPHRM, was COPIC's Director of Facility Patient Safety and Risk Management and Operations from 2014 to 2020. Ms. Dixon has over 20 years of clinical experience in acute care facilities, including critical care, coronary care, pre-operative services, and pain management. Laura holds a Bachelor of Science degree from Regis University, RICEP of Denver, a Doctor of Jurisprudence degree from Drake University, College of Law, Des Moines, Iowa, and a Registered Nurse Diploma from St. Luke's School Professional Nursing, Cedar Rapids, Iowa. She is licensed to practice law in Colorado and California. I would now like to hand over the floor to the speaker.
Okay.
Over to you, Laura.
Thank you very much, Ivan, and welcome everyone. We're talking about a very problematic standard for CMS conditions of participation, and that is restraint and seclusion. So I'm going to just do a brief introduction on why we are here. These are the headlines we don't want to see. We have it where we've got a patient where CMS did come in, and it talked about them doing a survey. 48-year-old patient strapped to a gurney, traumatic asphyxiation. And here, this went just a step further than just negligence. Psychiatric hospital, same thing, overuse of restraints, and very lax and very loose policy. So now they're starting to think about restraints again. One thing they're looking at is more RNs, not just nurses and CNAs, RNs. And they did find back in 2016, so not that long ago, the more RNs you have on duty, the less restraints were utilized. The use of restraints by using more RNs decrease the use of restraints. So I've included the link there for you where to find that particular article. The conditions of participation are what hospitals have to abide by if they want to receive Medicare funding, Medicare, Medicaid. And it doesn't matter which patient. It could be a Cigna patient, a Blue Cross patient, a Medicare patient. So deficiency reports. I mentioned no one wants to get that notice of deficiencies. If you're interested, you can tap into it. It has the tag numbers and the address, a brief description of what they found, and it's updated quarterly. So why are hospitals cited? Well, big one is they weren't following their own policy and procedures. So again, they're pretty serious on restraint and seclusion. I did mention the complaint manual. Keep it handy because there is a process to investigate, especially when it's involving restraints and seclusion. So I've got the information. That form, again, is in the appendix for what you need to report. Okay, so let's go ahead and start with the conditions of participation. Again, there are tags 154 through 196, and there are additional tags on training and death reporting. We're talking 50 pages of standards that are very in-depth. I know tags 162 is out of order, but it's a very short tag. That's it. There's one tag that addresses seclusion. It is the involuntary confinement alone in an area or a room where they're physically prevented from leaving. This is only used for the management of violent or self-destructive behavior. So that's seclusion. Let's go to the big meat of it, and that's restraint. I'm going to talk the standards and guidelines. Overall, it is in the patient rights section that all patients, again, no matter where they're located, have that right to be free from unnecessary physical or mental abuse and corporal punishment. In short, restraints. Maybe they're not following directions. They're disruptive. And again, they're trying to even take out medical devices. We've got them intubated. In doing this, the leadership, the governing body, the administrative leadership, they really have a responsibility to create that safe culture so that patients know they are free from unnecessary restraint and seclusion. So I want to talk falls. Remember, that was one of the big issues with some of the deficiencies where they were applied inappropriately for falls. So what are the minimum factors? Can we help them ambulate safely? Documentation is always big. They specifically, and I mean CMS, specifically mention the use of weapons in the application of restraints or seclusion. That's not okay for healthcare intervention. Now, I want to talk about what's not covered by this rule. What will the surveyor do? And this is still under tag 154. First off, they want to see what your policy and procedures are. Our next tag number is 159, and that gives us the definition. This is where we give it to manage their behavior or restrict their freedom of movement. And it's not a standard treatment or dose for that particular condition. So really, the appropriate use is that medication helps them function, helps them interact with the world around them. Now, this does, like a physical restraint, require a comprehensive assessment. When is medication not okay? Certain things, 161 talks about what is not a restraint. It's not a restraint, again, unless it's tied down or pinned down, or it's so bulky, patient can't use or bend their hand. Other practices that could rise to the level of restraint, they do include other types of restraint: jackets, ties, manual holding to force medication. There are certain age-specific items that may be restraint or may not. The one thing we do have to do is make sure, if whether it's restraint or seclusion or both, they have to be only used when least restrictive. And then, of course, we have to do safe and appropriate techniques in the application. Protocols for restraint and or seclusion, but there cannot be any standing order or PR in order for restraint or seclusion. Never. Then we have to notify our attending as soon as possible. Each order is limited to a time frame depending on the age of the patient. So again, here are the provider responsibilities, and I use provider to say physician or licensed practitioner. And again, the earliest possible time, discontinue the restraints and seclusion. So here's just what some of the policies should include. Hospitals, you determine who does that assessment and monitoring. Of course, it's within their scope of practice by state law. Again, what do you want to document? Definitely must document their behavior, and especially the intervention. One of the areas where you must have training. Training requirements have to be in the policy. So I want to talk about the 1-hour assessment rule. What do you want to look at? What's going on with the patient? How did they react to that intervention? If you do have your RN who's trained to do this 1-hour face-to-face, then they have to consult with the physician or provider as soon as possible. So documentation, we have to document our 1-hour face-to-face. All staff who have direct patient contact must have this at least yearly. And that includes your agency nurses if you're using them. As far as training to evaluate, this is what they're looking at. And that's, again, staff education must occur. They also have examples of triggers, but we do have to include in our education what type of restraints, how we recognize distress. So let's switch to death reporting with some of the time we have left. You must report to CMS. So what must you report? Any death associated with the use of restraint or seclusion. When no seclusion, you only use soft wrist restraints. Now, Joint Commission, I'm going to go through this fairly quickly. There are 10 standards. It's under provision of care. So you only use them when it's justified and warranted by the behavior. Training requirements, staff training requirements, who can order, who can discontinue, monitoring the patient, evaluating them. Like CMS, there is reporting of deaths. They do talk about the impact of restraints and how the restraint-related deaths, 40% from asphyxiation. Educate everyone. I don't care if it's a physician or an agency person. Educate them. They need to know what the standards are. And really, staff need to be well trained. Well, thank you everyone who participated. I appreciate so much what you do for your patients, and especially behavioral health patients. You know, in clinical medicine, where we can see the problem and fix it, that's the good part. That's the easy part. Where behavioral health, you can't sometimes see the problem. So I really have a lot of respect for those who work in behavioral health, because your challenges are somewhat more than those of us who, like I said, work in surgery or other aspects of care. So thank you. And Ivan, thank you very much for your help. I'll let you close us out.
Yeah, thank you, Laura. That concludes the session for today. Thank you everyone for participating, and you may all disconnect now. You all have a great day ahead. Bye.